Today, I'll be giving another update on COVID-19 therapeutics. This is the December 2021 update. And these are my disclosures. Today, I'm going to speak about two topics, molnupiravir and sotrovimab. Let's start with molnupiravir. Molnupiravir is an oral prodrug of N-hydroxycytidine, so it's really a cytosine analog. As you can see, molnupiravir is metabolized first to N-hydroxycytidine and then is triphosphorylated to the active compound N-hydroxycytidine triphosphate. NHCTP is a substrate for the SARS-CoV-2 RNA-dependent RNA polymerase. Although this drug does inhibit the polymerase, its mechanism of action is proposed to be through introducing errors into the viral RNA that impair SARS-CoV-2 replication through so-called error catastrophe. This slide shows the antiviral activity of NHC against SARS-CoV-2 variants of concern in vitro assays. And you can see the activity of this drug against the alpha, beta, gamma, and delta variants is in the micromolar to nanomolar range, with IC50s of just about 1 micromolar. These data show how NHC increases the error rate and decreases infectious virus out of proportion to the decrease in viral RNA. So if we look on the left side of the slide, here you see the control, and remdesivir leads to no increase in error accumulation in the RNA products, whereas NHC, or the active component of molnupiravir, leads to a substantial increase in error rate, which is dose dependent. Looking on the right side, we can see that with SARS-CoV-1 and with MERS, you have a decrease in the amount of RNA of infectious virus that is being produced, with a little decrease in the amount of RNA being produced, much lower levels of inhibition of RNA production. So there's plenty of RNA transcription occurring, but that RNA is defective because it's accumulating errors due to misincorporation. Preclinical safety data on molnupiravir raised a few concerns. There was reversible bone marrow suppression in dogs with dosing for 7 days or longer, but not seen in other species. The drug was mutagenic in the Ames test in bacteria, but not in standard in vitro mammalian cell assays, and there was no evidence of chromosomal damage. There was, however, dose-dependent growth plate thickening in rapidly growing rats. These are very young newborn rats, as well as toxic effects on developing fetuses. There was embryo-fetal lethality, teratogenicity, and reduced fetal body weights, as a result of which the drug is not recommended for use in pregnancy. Here you see the results of phase 2 studies showing a dose-dependent decrease in virus load. The participants here are stratified with initiation of treatment within 5 days of symptom onset or after 5 days of symptom onset. And you can see that the effect is greatest when molnupiravir is initiated as soon as possible after symptom onset. The Move Out trial was a phase 3 study of molnupiravir in non-hospitalized adults with mild or moderate COVID-19. They had to have laboratory confirmed SARS-CoV-2 infection within 5 days before randomization and onset of symptoms within 5 days before randomization, based on the data I just showed you that the drug was far more effective in viral suppression when given as early as possible. Patients were eligible for study if they had increased risk for severe illness from COVID-19, which included being more than 60 years old or having a variety of comorbidities, which are listed here. They could not be vaccinated against SARS-CoV-2, and the proposed sample size was 1,550 participants. Participants were stratified based on onset of symptoms, either 3 days or less, or between 4 and 5 days after onset at the time of randomization. And participants received 800 milligrams of molnupiravir, which was 4 200 milligram tablets every 12 hours for 5 days, or placebo, and were randomized 1-to-1 to active drug or placebo. This slide shows the baseline characteristics of the initial interim analysis population and then the full population. The reason I show the data in this way is that there was a planned interim analysis after the first 750 or so participants had reached day 29, and then the entire data set was analyzed after enrollment into the study was ended. Here you see the primary efficacy analysis for both the participants, and this, both cohorts, and this requires some explanation. There was an interim analysis conducted after the first 750 people reached day 29, as I mentioned, and that analysis showed that there was about a 50% reduction in the risk of disease progression, hospitalization, or death among the people who received molnupiravir, just 7.3%, compared to placebo, which was about 14%. This was highly significant and reached a predetermined threshold for halting further enrollment and randomization into the study. However, by the time the 750 people had reached day 29 and were analyzed, the study was nearly completely enrolled already, and so they went ahead and followed the remaining participants out to 29 days and then analyzed the full data set. And somewhat surprisingly, when the full data set was analyzed, the effects of molnupiravir actually were not as impressive as in the interim analysis. As you see on the right side, nearly 7% of molnupiravir participants progressed. That was about the same as before, but only about 10% of the placebo participants progressed, a much lower rate of progression, so that the reduction in progression rate was only about 30%. This is a much smaller effect than seen previously. And although still reaching statistical significance, it's a much more modest effect than had originally been observed. And here, just comparing the two populations, again, you can see that essentially the difference is much lower rates of progression among the placebo participants in the group enrolled from August 6th through October 2nd. That's the post-interim analysis population. And that you can also see that in the interim analysis population, whereas there were 8 deaths in the placebo group, there were no deaths in the molnupiravir group. There was 1 death in each group in the post-interim analysis population. So in the total population, 9 deaths in the placebo group and only 1 death in the molnupiravir group. Looking at subgroup analyses quickly, you can see that the effects curiously for time from randomization seem to be more pronounced in those who had symptom onset more than 3 days prior to randomization. That meant day 4 or 5 compared to less than 3 days. Also, there was a big effect in people who had gamma and maybe slightly less effect against delta and mu. They didn't reach significance, but the effect is all in the same direction. More importantly, there was a clear effect in people who were antibody negative versus those who were antibody positive. Now, of course, nobody had been vaccinated and people could not have had a prior episode of COVID-19. So presumably having antibody positivity was a reflection of the time since infection, and that people who were longer time from infection and had already begun to develop an antibody response were less likely to benefit, although that result seems to be discordant with the results shown at the very top, so still bears some explanation. If we look at the safety data, the FDA reviewed the safety data submitted by Merck and found no notable safety concerns. They focused especially on the clinically meaningful abnormalities in leukocyte, lymphocyte, platelet, and hemoglobin values, and these were rare and occurred at comparable rates in both the placebo and molnupiravir arms. So in conclusion, molnupiravir reduces the risk of hospitalization or death among adults with mild to moderate COVID-19 who are at high risk for progression to severe COVID-19, but the effect overall is modest, just about a 30% reduction. Molnupiravir appeared generally safe in adults with mild to moderate COVID-19, but because of safety issues identified in the non-clinical or preclinical work, the drug is not being recommended for use in pregnant women, and there's active discussion about exactly what limitations or restrictions should be imposed in terms of use in women of childbearing age. Molnupiravir has been granted authorization in the United Kingdom. The US FDA reviewed the data, but we are still pending as of today, December 9th, a final decision on the emergency use authorization of molnupiravir and exactly what the terms of those uses might be. Well, let's turn quickly to an update on sotrovimab. Sotrovimab is a human monoclonal antibody isolated from a survivor of SARS-CoV-1 infection. So there's cross protection here. It targets a conserved glycan at position 343 in the S protein. And the Fc domain of this antibody has been modified genetically to introduce the LS substitutions, which alter the affinity of the Fc domain for the Fc receptor, leading to a much prolonged half-life of the antibody. The COMET series of studies were phase 3 trials conducted with sotrovimab, and the top-line results of COMET ICE had previously been discussed in one of our sessions, but have subsequently been published in full in the New England Journal of Medicine with an even more complete update of that I'll be showing you. And so this was a randomized double-blind placebo-controlled trial in which participants received either sotrovimab 500 milligrams intravenously or placebo. And again, as with all of these studies, was done in high-risk outpatients with symptomatic COVID-19. The primary endpoint was the proportion of patients with hospitalization for more than 24 hours or death due to any cause through day 29. You can see the schema here. It was an even randomization, and the participants were stratified based on age above or below age 70, duration of symptoms, very similar to the molnupiravir trial, and also by geographical region. For the sake of time, I'm just going to skip directly to the results. And what you can see is there were about 300 participants in both groups. There was looking at the overall primary outcome, there were only 3 participants in the sotrovimab group compared to 21 participants in the placebo group who required hospitalization or who died. There was only a single death, and that occurred in the placebo group. This led to a calculation of a relative reduction of the risk of progression of 85%, similar to what's been observed with other monoclonal antibodies used in this setting, and this was a highly statistically significant finding. Now, subsequently, just as in the case of the molnupiravir data, the more complete data set was analyzed, now including over 1,000 participants, roughly 530 in each group. And you see that these data hold up. There were 30 progressions in the placebo recipients and only 6 in the sotrovimab group. There was, again, the only deaths that were observed were in the placebo group. There were 2 deaths in that group and none in the sotrovimab group. And this led to the estimation of an adjusted relative risk ratio of 0.21, meaning about an 80% reduction in the risk of hospitalization or death compared to by those who received sotrovimab compared to placebo, which was highly statistically significant. Now, COMET TAIL is a study that compared intramuscular to intravenous dosing of sotrovimab in the same kind of patients, that is, people with mild to moderate COVID-19 who are at high risk for progression but are not yet hospitalized. This study included pediatric patients as young as 12 years of age and adults. It was initially a 3-arm study in which all 3 arms included dosing of sotrovimab, either 500 milligrams intravenously, as in the COMET-ICE trial, or 2 intramuscular arms, 500 milligrams or 250 milligrams. An independent safety monitoring committee recommended halting enrollment of the 250 milligram arm when it appeared that the lower dose arm was inferior to the standard dose arm. And recently, the top-line results of the comparison of the 2 500 milligram arms was released. The progression rate in the sotrovimab 500 milligram intramuscular arm was 2.7%, and in the IV arm, 1.3%. That led to an adjusted difference of just over 1%, which fell, the confidence limits you can see there, fell just within the predetermined limit of the upper bound, which was set at 3.5%. That's a very narrow confidence limit. Remember, we're used to seeing confidence limits of 10% in many non-inferiority trials. So this is a very tight margin, but IM dosing was non-inferior to intravenous dosing. There were low rates of serious adverse events and grade 3 or 4 adverse events, less than 1% in both arms that were observed in the headline data. But all we have really are these data from a press release, and we're awaiting the posting of a preprint with much more detailed information. I want to say just one word about the activity of sotrovimab against the Omicron variant of concern. I'm going to leave to the other speakers more detailed discussion of the newer variants, but you can see in these data that were just posted 2 days ago that compared to wild-type virus, there is a slight shift in the amount of antibody, the IC50 in a sense, of sotrovimab required to neutralize Omicron, but that still falls in the nanogram per mil range, concentrations that are easily achievable with the 500 milligram dosing, suggesting that sotrovimab is likely to retain activity against Omicron, which is in distinction to some of the other monoclonal antibodies, including casirivimab and imdevimab, which are now currently widely used in the United States. So to summarize, sotrovimab is effective at preventing disease progression in at-risk outpatients with symptomatic COVID-19. Intramuscular administration is non-inferior to intravenous administration and may make the logistics of administering the antibody much more straightforward. Preliminary data suggests sotrovimab retains activity against the Omicron variant, but of course we'll have to see clinical confirmation of that observation. Thank you for your attention.